Dr. Peter Paul Eriki, actually based in Uganda, in East Africa, as you can see. Now, the most interesting thing is that I started from a very humble background. Went to university in Makerere University, where I did, of course, MBS CHB, and then also went back and did a degree in internal medicine and specialized in internal medicine. After that, I went to UK, where I did a high diploma in tuberculosis and chest medicine in University of Wales. After that, I went to Harvard University in US, where I did, of course, naturally, when you do tuberculosis, you are drawn to a disease which is a public health concern, and it's a disease of people. And therefore, you need to know public health as well as epidemiology. I attained that and then came back home. I was made to head the national program of tuberculosis. And during the practice, which of course I should have mentioned for internship, just going one step back, I was posted to a rural hospital, a 100-bed hospital, a single doctor, literally operating every day. I cannot remember how many cesarean sections I did during that time, but it was a very rewarding experience. One, it brought me closer to how people actually live in communities. Secondly, giving service with dedication propels you to the future. And indeed, it set my future. And then that, of course, made me access quickly going back to the university to do master's degree in internal medicine, which I enjoyed. During the process, I realized there was a problem of tuberculosis. So I got inclined in that direction. And indeed, I did internal medicine, went and specialized in TB and chest medicine in UK, and as I mentioned, eventually went to Harvard University, where I got much more knowledge on how to handle public issues, not only living with the numerator, but also having a denominator with you to appreciate where are these people coming from. Well, the most important thing which there's quite a lot which I participated in. When I was in the regional office, for example, of WHO, we had conducted a study to look at issues of community initiatives, because this is the grassroots of where things happen. We did it in the 46 countries. My colleague was given to be in charge of organizing a meeting for Francophone, which he did in Abidjan in West Africa. Then I was given the honor to organize a meeting for the Anglophone countries, and we held a meeting in Arusha. One fascinating thing which came out from this meeting is who is the prime mover of these initiatives. They fell into three categories. You get some big brains, let's say in the World Bank or in Geneva or other groups, said, oh, that society needs this and that. So the pipe literally is thrown there. And then say, swallow it. That's what you need. Normally, when they stop that process, it ends there. And they'll call it by the name where it came from. That's the World Bank project. This is this, and stops there. Then the second one was prime mover. When, let's say, I go to our village and I discuss with the people there and say, look, you guys, there's something which is going in our village. This can be fixed. Some of them say, no, who are you? This thing we've had it for so many years. And so on. Who are you to talk like this? Even our forefathers had this. Then others will say, no, this is our child. He's one of us. He must have seen something. Let's listen to him. That type of initiative will hang on a little bit because they seem to get involved. Then the last one is somebody goes to those communities and says, what problems we have here? You bring them on the table with you. Now, they are participating as part of the equation. They'll throw in examples, say this is the problem here, this is this. Of course, you have in the back of your mind how you want to bring in what you think they could bring a change. But that particular type of approach makes a lot of difference. They own it and they begin using it as part of them. If all of us could learn that, as we engage societies, communities, and that is why I found that example of the Sultan played, how to bring a person who is relating to the people, who is recognized, to be part of the equation and probably lead it. What I didn't tell you is that Bill Gates came and he asked me, how do you think of this group? I said, I think this is a breakthrough. And he gave them $8 million to continue the exercise. Now polio is no longer an issue over there. So in short, when you do policies, take the person, the consumer, to be part of the equation, not a recipient. And be prepared to give them a leeway to lead. And you become supplementary. This can bring a real mind change and a difference. Indeed, based on this, my boss, who is now the African Center for Global Health and Social Transformation, has in fact championed the process, what they call community engagement strategy. And that is now influenced a change in the country to think that you need to have communities involved and change the process of policy direction to be generated from bottom up, not top down. And during that process, bring all the actors, be them NGOs, be them government agencies, be them donors and so on. They should all work together to develop a common program. This way, our societies will prosper. The world is getting smaller, and it's the same people. We are together. We have global commitments where our leaders get together. For example, they have just been in New York, and they have been discussing very, very important issues. One of the forefront ones is the climate change, which is really a true problem if not well addressed. We shall leave our children in a very difficult situation, which they will not spare us for because we didn't do enough. Then you have the World Health Assemblies of Health. You have the Arab world, they organize very big meetings. You have just had a very big expo in Dubai. I know you've been participating in that. All those are very good opportunities. Now, what is important in those is the linkage between us in that global arena and those who are back at home. When those policies come down, those declarations and pronouncements, it is up to us, the local indigenous, working together with our partners to develop something which will be meaningful to our own populations. It's not one jacket fit all. Neither is it cut and paste. It must be a well thought process. Now, based on what that Professor Omaswa did, who is part of the publication, one of the authors of that publication with Lord Crisp, and if read deep, you can find a chapter in that, small contribution in that book. That philosophy of engaging communities has now tickled the government, and they have now developed what they call a parish. A parish is the lowest segment of administrative unit model, which they are going to use to support these communities. It's a beautiful proposition, and the country is excited. They are now in the process of seeing how this is going to work. They keep, of course, consulting Professor up and down because he did some pilots in a few districts, and the people are really seeing when you engage the populace as part of the equation, you see the difference. Empower them. Let them be in the leadership. They make mistakes, but you correct them. And this is the way forward. But don't forget, North-South, South-South collaboration is paramount. When I was again in the regional office, I was invited to a big conference. That was just when the Mandela had just gotten out of prison, and they were beginning to think about their tuberculosis program. I was one of the keynote speakers in that South African meeting. The title of the meeting was Back to the Future in TB. I gave a very roving, very touching talk to them because I realized, being sophisticated, they were using back techniques for diagnosis, and they were using the Western world, particularly American-oriented type of treatment, 2-drug regimen, and they were not even completing, making sure the patients completed the treatment. They ended up with multiple drug-resistant TB, which they're still fighting with up to now. So when I gave the talk, there was a famous man called Stiblo. He was from Netherlands. He did a lot of work, and in fact, when they declared short-course chemotherapy a very effective treatment for TB in 1982 in Buenos Aires, he went ahead and tried it in Tanzania, Nicaragua, and Malawi. And he used the drug and improved the cure rates to over 80% of the detected cases. People did not pay a lot of attention to that success story. One time I asked myself, why did he choose Tanzania and Nicaragua? These were socialist countries. I imagine that South Africa is much more of a capitalist than others, and it was easier to work with these groups, and they were able to reach the patients and let them take the care. Getting back to your question, I think the way we teach and train people may not be very complete. Number one, we take a person as TB and is wrote in TB, is closed in that segment as a single process. But this is a human being. He should be looked at as total in totality, all aspects, including social. Because most of the issues you have described, some of them are mindset, others are socially driven, because stigma has been spilled over there and they're treated worse than lepers. That's one. Two, we misadvantage. When I was actively treating patients in Mulago, in the ward, I innovated one thing. I used the older patients who have been in the ward and who are improving to mentor those who were coming in new. And I learned the message they were passing. He said, "Oh, John, don't worry. We came worse than you. Look at us now, we're better. You listen to the doctors, take your medicine, you'll be okay." And the other thing is you need also to talk to the relatives who come with him. And be prepared to extend the process to go and check the households and the children, particularly in those households, because they may be infected. Looking at totality should become part of our training. The techniques have improved. We have now gene experts and so on. And indeed, the world has realized and brought the disease now to the 32 high-burden countries. It used to be all over the world. Now it is now closing down. But if we do not engage what you have just suggested, engage in communities, let them know. Like now, when they talk of this Paris model, which the government is pursuing in Uganda here, I'm really very actively telling them, use that model to flush people out who have been coughing for more than 2 weeks in those communities, and let them be brought to the facilities and be checked out. This way, you will flush out TB in the rest of the communities. Nobody is safe. And therefore, in the early parts of our discussion, I did mention the importance of working together. These global opportunities are there. Of course, the engagements have got different interests. Somebody can be interested in working with you and looking at what am I going to get out of this. But others will still feel, how are we going to impact in society? And secondly, how do we develop safety checks and preparedness for the future, just in case something like this comes again? This pandemic has taught us and has given us clear lessons that ill preparedness can lead to a lot of unnecessary lives. You know very well what happened in India. It was very, very unfortunate indeed. What could we have done differently? And to not only be left to the nationals, because these are transcending borders. The diseases come from far. We need that collaboration. And then international honesty. Nobody should sit back and hide something potentially explosive. Perhaps if that gets to be known, the world could quickly move in there. Stop it at the source. This is what I think. Working together, looking at these opportunities like you talk about the UN bodies, the World Bank, all these groups, they should support a process where they are, you would call them intelligence mechanisms, established in all corners of the world, so that we can detect anything which is potentially destructive to humanity. The spirit is collaboration and working together. There are quite a lot of debates ranging with the relevance of these big organizations and what have you. You imagine if you don't have them, how would you get these people to meet together, these experts? Unless associations like the ones you are setting up really get grounded very well and very clearly working together. But of course, they'll get to a point where some people will not listen to them because they'll believe they know it all. Who are you to tell us? Etc. And that will bring a process of complacency, and the diseases will hit us so badly. We need some of these organizations still going on. Now, turning to clinical medicine, I did mention a reason why I went to do public health. I'm a clinician. It's because clinicians are working with numerators. Next patient. Next patient. Next patient. You are not thinking, where are they coming from? Can we look at possibilities of extending to look at the source of these problems and we fix them? This is where the need between the clinicians and public health workers and communities at large need to work together. Clinicians will be able to even find treatment to sort out a problem. That is very important. Those are index cases. But how do we look at possibilities of going upstream so that we stop these things from coming? Somebody will, of course, say, wait a minute, why should we cut off where we're getting bread from? That's looking at a narrow angle. That's a business-like. But you don't need to make business by watching a lot of people die. So clinical work is extremely very important. Like now, these researches, the malaria vaccines, the rapidity with which the world responded to COVID and coming out with credible vaccines, which are not even given the normal trend to be tested to find out what. So leaving people speculating a lot of theories, misinformation and what have you. But what matters is they have been able to do this. Likewise, clinicians describe what they see when a problem has affected individuals. Documenting this will always be very important for teaching and also warning others. When you see something like this, pay attention. So, togetherness, all of us must be open-minded. The shocks are not stopping at COVID.